Morning and welcome to today's Platt Institute webinar. Today, we're going to be talking about changes that have been made in the regulatory and occupational licensing areas as the result of temporary executive orders during COVID. And we're also going to try to look ahead into the future and discuss how some of those changes might be integrated as part of a post-pandemic economic recovery. A few housekeeping notes. You can type in your questions for our guests during the presentation. You can use the Q&A feature at the bottom of your screen or the chat function at the bottom of your screen, and we'll try to keep checking both of those places. Today's presentation is being recorded and will be available along with the slides on the Platt Institute website later today or tomorrow. And our first presenter is Dr. Ed Timmons. Dr. Timmons is a professor of economics at St. Francis University and the founding director of the Denise Center for the Study of Occupational Regulation. Dr. Timmons, welcome.
Thank you, Laura, and thank you so much for inviting me to speak today.
Absolutely. We will let you do your thing, and if there's any questions, please feel free to start typing them into the Q&A and chat.
All right, so I'm going to get my slides started here. So I'm going to break my comments up into 4 different pieces. There we go. So I'm going to be talking about occupational licensing and healthcare. I'm going to talk a little bit about why we have occupational licensing and some of the challenges, some of the costs that it unfortunately presents. I'm then going to spend some time talking about how the pandemic has led to some states, including Nebraska, enacting some waivers and reforms. And then I'll spend some time talking about what we can take away from some of these reforms and what lessons perhaps we might learn from some of the changes that we've seen. So occupational licensing, let me just give a brief discussion of what we're talking about here. I'm sure most of you already have some familiarity with this, but occupational licensing sets up a scheme where individuals that are looking to enter a new field have to go to Lincoln and get a piece of paper in order to begin working. And it has grown tremendously with respect to the amount of workers that are licensed in the United States. In the 1950s, about 5% of workers were subject to occupational licensing. And today that figure is more than 1 in 5. So more than 20% of workers in the United States now need a license to work. And in order to get that license, individuals might need to pass exams, they might need to pay fees, or they might need to meet a variety of other requirements in order to begin to work. Where we see licensing most prevalent in the United States is in the arena of healthcare. And I mentioned that 1 in 5 workers is licensed in the United States. In healthcare, it's more than 40%. And this is according to statistics of the Bureau of Labor Statistics that thankfully now tracks the fraction of workers that are licensed. Now, licensing shakes out quite differently if we compare it to other developed countries. And for example, there was a recent study that compared the United States to other European countries, and I'll show that graphic to you now. So what this graphic breaks down is how the United States, which is the dark blue in each of these 3 comparisons, compares to the EU, which is the sea blue or lighter blue, and also to Nordic countries, which is the green column in each of the comparisons. For example, if we look at specifically health practitioners, and technical workers, the United States has about 73% of workers having a license, whereas the EU has about 48%. And we see a similar discrepancy, not quite as large, in healthcare support, where the United States has about 46.5% of workers licensed, and the EU has 36%. Now, it's interesting to note that if we look at the entire labor force, the EU has roughly the same fraction of workers subject to licensing. So what's going on with respect to the United States? And it's also important to note that if we look within European countries, you're going to see significant discrepancies as well. For instance, in Belgium, only 17% of workers in the healthcare industry are licensed, whereas in Croatia, 63% are licensed. If we look in a country like Belgium, health professions like occupational therapist assistants or physical therapist assistants or dental assistants, which are important contributors to healthcare, they are not licensed in Belgium. And these workers are licensed in Nebraska and are licensed in a number of other states in the United States. So comparing across countries, we do see some interesting differences emerge with respect to the fraction of workers in healthcare that are subject to licensing. So why do we license in the first place? So it's been framed a number of different ways. One rationale that's oftentimes given for why we license is that it solves this problem in economics that we call the Lemmons Problem. And essentially what the Lemmons Problem is all about is that we as consumers have less information about the credentials or the skills of a professional than the professional does. So if we add licensing, we'll at least have some bare minimum amount of faith that our professional or our doctor or our dental assistant has met some bare minimum amount of education. And in general, there has been theories that have been put forth that licensing just advances human capital. You have a better educated, better trained workforce. But when we think about these rationales, it's important to note that the market has changed and evolved a lot. It's changed a lot since the publication of the paper looking at the Lemmons Problem, is a paper by George Akerlof in the 1970s. And it's also changed dramatically since when these laws were originally passed. Consumers have access to a lot of information that they didn't have access to before. For instance, with online platforms like Yelp and like Facebook and Google, consumers can get a lot more information about the reputation and qualifications and the quality of professionals that they were able to obtain before. So the market has changed a lot relative to when these laws were passed and when these theories were advanced. Now, occupational licensing also results in significant costs as well. It's been well documented that occupational licensing increases prices anywhere from 3 to 16%, depending upon the study that we're looking at. Licensing also results in fewer workers. The supply of workers decreases by anywhere from 17 to 27% as a result of occupational licensing. There's also been research that shows that although occupational licensing increases prices, the increase in quality, essentially the amount that consumers should be willing to pay for that increase in quality, is not sufficient. So consumers end up paying more than what they should. They don't get the full value of the occupational license with respect to the price that they pay. Occupational licensing also reduces mobility. In licensed occupations, we see significantly less movement from state to state. Estimates suggest as much as a 20% reduction in interstate mobility as a result of occupational licensing. And lastly, it's not entirely clear that consumers really care all that much about occupational licensing. There was a very interesting study that came out earlier this year that looked at consumers using an online platform for home services. And what they found is that consumers seem to care a lot more about the online rating that a practitioner receives than whether or not they have a license. Consumers didn't really care so much about whether or not they had a license. They were much more interested in the rating that they received online. So occupational licensing may have some of these benefits, but it's important to note that there are a number of costs, a number of consequences associated with these laws. So if there is a place where occupational licensing perhaps is necessary, it could be healthcare. I mean, healthcare is different. You are potentially putting your life on the line when you're receiving care from a physician. But it's also important to note that physician licensing is very broad. If you get a license to be a physician, essentially you're able to do, at least according to the state, any aspect, whether it be surgery, specialty care, you name it, the license essentially allows you to do all of that. Now, of course, hospitals know better. Hospitals want doctors to get additional private certifications in order to do these specialty services. And if we think about the effect of licensing, licensing does reduce supply. Licensing very well can contribute to shortages of care. The economist Milton Friedman liked to talk about the Cadillac effect, this idea that it really would be great, if we're talking about cars, it would be really great if every consumer would have access to a Cadillac, but not everybody can afford a Cadillac. And the same is true in healthcare. It'd be really great if everybody in every instance could see a physician for healthcare, but is it better for somebody to go without any healthcare at all? And I think we could all agree that some amount of healthcare would be better than none. And when we're thinking about the transferability of licenses, I mentioned that licensing reduces mobility of professionals. A lot of times licenses simply will not transfer. There'll be all kinds of barriers that prevent individuals from moving from state to state. So you can see individuals having some difficulty finding healthcare, particularly in rural areas. And like any other state, like most states, you're going to find a lot of rural areas in Nebraska. And individuals might find that they have to travel great distances in order to receive care. And if you opened up mobility, if you allowed workers to move more freely, you very well might have more professionals, more practitioners locating in those areas. And there's a variety of other remedies to get at this as well. So let me talk a little bit about what states have done in response to this pandemic. I think policymakers should be commended for acting very quickly in response to this crisis. And states have implemented a number of emergency waivers and emergency reforms in response to this crisis. For example, a number of states have waived licensing requirements. So for instance, if I want to work as a nurse and for a variety of reasons, it could just be that the exam's not happening, I'm unable to take my licensing exam, what some states have done is they've allowed nurses to begin working in a transitional phase or under the supervision of another licensed nurse without having passed the licensing exam. We have also seen, and Matt's going to talk more about this, but we've also seen states expand scope of practice for a variety of health professionals. And this essentially allows healthcare professionals to do more than what they can typically do. And states have also enacted some other reforms, getting at the idea of mobility. A lot of states have allowed healthcare professionals to begin working in their state very quickly, right? Bypassing the typical process for transferring licenses. And Nebraska is one of those states that has enacted such a reform. Other states like Nebraska have eliminated renewal fees for occupational licenses. They've eliminated continuing education. Continuing education, it's annual or biannual requirements where healthcare professionals will have to complete certain courses or attend certain events in order to maintain their license. And these requirements have been waived in Nebraska for a number of healthcare professionals, and several other states have enacted several waivers. And Nebraska has also allowed physicians to work with more physician assistants. That was another part of the executive order that the governor issued in the state. So we do see states being quite proactive with respect to this pandemic and enacting a number of reforms. Is there a possibility for there to be some movement after the pandemic ceases? And I think one area that makes a lot of sense is recognition. We've seen states recognize licenses of out-of-state medical professionals, and in order to encourage mobility and to ease some of the shortages that were prevalent before the crisis, I think it would be helpful if states would consider enacting this type of reform permanently. And this type of reform isn't just applicable in healthcare. I think universal recognition makes a lot of sense in other industries as well. You might find that there might be a shortage of skilled tradesmen or workers in specific areas, and allowing workers to enter Nebraska from out of state might ease some of these shortages and might help businesses find access to a pool of labor that they need so that they're able to continue to be productive and to produce goods and services. Another important thought that I think licensing boards have to consider is licensing boards are meant to promote consumer safety, but they have to weigh that with making sure that there's adequate personnel. And I wrote a piece with a physician who is completing his residency, and we argued that physician licensing boards perhaps should move towards adopting a dual mandate of consumer safety and making sure that there's adequate personnel. If you do end up promoting shortages via the licensing process, that hardly seems to be in the best interest of consumers. Another question that states can ask themselves is, do my regulations look more onerous than another state? I know, for instance, that Nebraska has very restrictive regulations on barbers and cosmetologists, and you have reduced them. They were at 2,100 hours for both professions, but they've come down to 1,800. That's still higher than a number of other states. Nebraska also has, it's tied with New York, for the most hours required to be a massage therapist, a ancillary part of the healthcare profession. So if Nebraska happens to be well outside of the norm of other states, I think it makes sense to revisit and take another look at those regulations. And as I pointed out, you do see these significant differences between the United States and Europe. If these differences exist, I think it's important to think a little more carefully about why we have these differences. And then lastly, the federal government has enacted reforms for nursing aid requirements in the 1980s, 1987 to be precise. The federal government enacted a reform that required nursing aides, if they're working in nursing homes, to be subject to licensing. A number of states have revised these rules, and the federal government's revised these guidelines. I think it's important generally to reconsider, particularly if states, again, have restrictions that are above and beyond what other states have or what the federal government mandates. I think it's important to carefully reconsider those. This pandemic gives us an opportunity, I think, to reconsider a lot of these regulations. Thank you very much. And I have the link. I think my slides will be shared with everyone afterwards. I have the link to our website, the Denise Center, if you'd like to take a look.
All right.
Okay, we will move to the other one. We do have a question that I thought I'd throw out there right now. Mobility has been a problem in many professions. Nursing has an interstate compact to allow quick transfer between states, and EMS for paramedics and EMTs is now working on setting up a compact like that. Is this the way, compacts, is that the way that we should be addressing this, or are there other ways to address this for paraprofessionals?
That's a very good question. Compacts can be helpful, but they are limited generally in their scope. They don't allow individuals to permanently set roots in Nebraska. They'd still have to be subject to the licensing by endorsement process. So they're very helpful in individuals moving across borders. If an individual wants to come from Iowa into Nebraska, they would be able to do that via the nurse licensing compact. But if they want to permanently move to Nebraska, the compact doesn't help a whole lot with that. And I also worry with compacts, you have an additional layer of bureaucracy. Will there be a tendency for occupational licensing restrictions to become more stringent? There's this tendency for there to be some degree of uniformity, harmonization as a result of the compact. And my concern is, will you see more and more states moving more towards the more stringent rather than taking a careful look and thinking about perhaps moving in the other direction? I think recognition is less likely to result simply accepting another state's license without that additional layer of bureaucracy, I think is the better approach.
Okay, thanks. Nicole?
All right. Well, next up, we have Dr. Matt Mitchell, and he's the Senior Research Fellow at the Mercatus Center at George Mason University. He also is an adjunct professor of economics at George Mason University, as well as the director of the Equity Initiative. And this is a project where they're working on reforms that break down barriers to marketplace entry and competition. So, Dr. Mitchell, I'll turn it over to you. Thank you so much for joining us today.
Excellent. Thank you so much for having me. I'm delighted to have the opportunity to chat with you today. My plan here is to go over a couple of recent papers that we've released around the pandemic and sort of build off of some of the work that Dr. Timmons has already discussed. But one of them is looking back, sort of backwards at what are the barriers to employment and to better health that the states have imposed. And then the other paper is looking forward. What can we do after the pandemic? How do we address some of these rules and regulations that have been suspended? So first of all, the looking back. The paper is called First Do No Harm, 3 ways that state policymakers can make it easier for healthcare professionals to do their jobs. There are 3 specific types of policies that we recommend. In addition, of course, we would also recommend some of the things that Dr. Timmons has already talked about, easing licensing rules. But in addition to that, we recommend eliminating certificate of need laws, easing scope of practice rules, and removing barriers to telehealth. So I'll talk about each of these in turn. So first of all, certificate of need laws. What are these? Well, these are rules that essentially in 35 states and the District of Columbia, if you want to open or expand your healthcare facility, you have to prove to a regulator that your community needs the product or service that you're trying to offer. They are not going to be assessing your credentials or your past experience or your safety. Instead, they're simply going to be second guessing your claim that the community could benefit from the service that you're trying to offer. The process can take months, sometimes years. It can cost tens, even hundreds of thousands of dollars in compliance costs. And most controversially, when you go before the regulator, quite often your competitors will be sitting on the board. And if they aren't, in every state that has a certificate of need law, competitors are allowed to come before the board and protest your application to expand your service. So for that reason, it's been considered by antitrust authorities to be an anti-competitive regulation. So I have this, well-known chart here. Everybody I'm sure has seen this. The idea is flattening the curve. But I want to point out something here. Remember, of course, that the idea with flattening the curve is not necessarily to ensure that nobody gets it or that fewer people get it even. The general consensus is among epidemiologists is that COVID the cat's already out of the bag. And so most of us are going to get it. But instead, when we flatten the curve, the idea is for not all of us to get it at the same time. And that's important because it won't overwhelm the healthcare system. Well, that raises an important question of why would the healthcare system be so overwhelmed in the first place? And while certificate of need laws aren't the entire reason for that, they are one reason. And that has to do with this bar, this idea that there is a certain capacity of the healthcare system. And states without certificate of need laws, we have a higher capacity. The bar is not so low, and so it's easier to get under it and not overwhelm the system quite so much. So as I said, they're found in 35 states in the District of Columbia. Let's take a quick look at Nebraska's certificate of need laws. It's actually more limited than in many states. It's mostly relative to long-term care. But Nebraska has 4 certificate of need laws requiring a certificate of need for intermediate care facilities for those with intellectual disabilities, a certificate of need for long-term acute care, one for nursing home beds and long-term care beds, and also for rehabilitation. So the research suggests that those states without certificate of need laws have lower per unit costs in terms of obtaining care. So the cost of everything from a hip replacement to a coronary bypass surgery is lower in non-con states relative to con states, and they also have lower per person expenditures. So the amount spent per person or per capita on either healthcare or on physicians is lower in non-con states relative to non-con states. And it's about $200 per person per year. So it's a pretty significant amount. We also find that states without con laws have greater access to care. This is probably the most studied aspect of con. We find that there are about 30% more hospitals in non-con states relative to con states. This is on a per capita basis. There's more ambulatory surgery centers, about 14%. There's more rural hospitals and rural ambulatory surgery centers. People don't have to drive as long a distance to obtain care in non-con states relative to con states. They are less likely to leave the state or leave the county in search of care. There are more hospitals offering MRIs, CTs, and PET scans. There's more hospital beds in non-con states relative to con states. There are more dialysis clinics and hospice care facilities in non-con states relative to con states. And there's also less racial disparity in the provision of care in non-con states relative to con states. That is, in con states, African Americans in particular have less access to care than in relative to non-con states. And finally, research suggests that there's higher quality of care in states without con laws relative to states with con laws. So that's the general consensus among the economic literature on certificate of need. But moving on to another area of reform, scope of practice rules. So one way to think about scope of practice is, while what Dr. Timmons talked about in terms of licensure is whether you are licensed or not, scope of practice, you might think of that as the stringency of licensing rules as they apply to particular practices. So it's really important, or professions, it's really important in terms of highly trained medical professionals like nurse practitioners, physician's assistants, nurse anesthetists, and the like. And the idea here is how much leeway, how much freedom do they have to practice to the full level of their training? How do the laws permit that? And a couple of important constraints on that are whether or not they have to have supervision by somebody like a physician. This is really important, again, in the case of COVID, because you can increase the total capacity of healthcare providers if you allow nurse practitioners and physicians' assistants to practice to their full scope of their capacity. You can increase it, I think, by something like 50 or 60% increase over the number of healthcare professional over just physicians. It's also important because it means if a physician doesn't have to supervise a nurse practitioner, it can free them, and isn't having to see every single patient, it can free them up to deal with the more technical and difficult cases. So it allows essentially greater comparative advantage, specialization by comparative advantage, which we know from economics is an important aspect of productivity. So what are some of the barriers to scope of practice rules? Well, one is simply the degree of practice authority that somebody like a nurse practitioner or physician's assistant has. And here you can look across the states and see varying degrees of practice authority. The good news is that nurse practitioners in Nebraska, even before the crisis hit, had full practice authority. So in this regard, Nebraska is ahead of many states. However, they do not have full prescriptive authority. They're not able to write prescriptions to the degree that other states like Alaska and California permit them to. Another aspect of this is how these scope of practice rules vary from different types of medical professionals. So again, Nebraska permits relatively broad scope of practice for behavioral health providers as well as for midwives. But on the other hand, at least before the crisis hit, I don't know if this has changed since, Nebraska has more limited scope of practice for pharmacists and dental hygienists. On the pharmacists, I'll plug a paper by Dr. Timmons that he did a few years ago for the Mercatus Center, looking at what are called CLIO waivers, where pharmacists are essentially permitted greater freedom to offer tests to patients. And what they found was that there's great variation among the states in terms of their how much freedom they give pharmacists to do this, but they found that pharmacists in states that have more leeway to offer these types of tests, they are not overwhelmed. They are able to perform all their other tasks just as easily. It doesn't seem to be impinging on their supply of other types of work. People are excited about this type of reform because often pharmacists are, again, these are highly trained professionals. If they are permitted greater scope of practice, it can increase access to care, potentially lower the costs, and permit more people to obtain high quality care. So what we find in general on the research on scope of practice is that states with broader scope of practice rules tend to have lower costs of care. For example, 16% lower cost for well child checkups, but there is no evidence that there's a discernible difference in outcomes. Quality is no worse in states where highly trained professionals like nurse practitioners and physician's assistants have greater scope of practice. One of the highlights of my career is a couple weeks ago, I was able to, for the first time, author an op-ed with my father. And my dad is a 40-year physician. It was fun to write this piece with him because he and I were essentially making the case that his competitors nurse practitioners and physician's assistants should be allowed to offer more care and compete with him more, not necessarily for all cases, but for, again, cases where you don't necessarily need somebody as highly trained as a physician in order to offer care. All right, the third type of reform I want to mention is barriers to telehealth. So as I'm sure many of you know, telehealth is basically the idea of offering diagnostic and even treatment prescriptions and the like via telehealth, via technology. So it may be a online consultation using an iPhone or an iPad. In the future, we may be able to pair this up with other types of emerging technologies, things like otoscopes that can connect via Bluetooth to your telephone, your iPhone or your iPad. Even now, things like Apple Watches are able to monitor all sorts of things from temperature and heartbeat to oxygen levels and transmit that information directly to caregivers. It's interesting, by the way, a quick note on the oxygen level monitoring. Apparently this technology already exists on iPhones, but the FDA will not let Apple turn that technology on because it hasn't gone through all of the approval process. So we're starting to see, of course, and we saw this at the beginning of the pandemic, there are two types of errors that can happen when the FDA evaluates treatments. There is one error where they allow a bad treatment that doesn't work or that maybe has bad side effects to go through, and the FDA has a very, very strong incentive to make sure that doesn't happen. But there's another type of error where they don't allow good treatments to go through, and they have very little incentive, except perhaps during a pandemic when everybody's watching. They have very little incentive to make sure that they don't make that kind of error. Yet it can be very costly. There's no reason to believe that that second type of error can't in some cases be even more dangerous for the public's health than the first type of error. There was a recent article in the Washington Post a few years ago noting that in the United States, the skin protection from suntan lotion and from the cream that you put on your sunscreen, there we go, losing my words there. The protection from sunscreen in the United States is about 20 years behind that of Europe because the US FDA has just been far more restrictive than the European version of the FDA. So what are the barriers to telehealth? Well, one type of barrier is that in many cases an in-person examination is required in order to write prescriptions. This was the case in Nebraska, at least before the pandemic hit. I'm not sure if that's been eased since then. Another type of problem is that in many states, thankfully Nebraska is not one of these, you actually have to have what's called a telepresenter with you. So the idea here is, yeah, you can access a physician via an iPhone or an iPad, but you have to have a nurse sitting right next to you doing it while you're doing that. Well, that sort of obviates the whole point of doing telehealth because most people don't have a nurse in their house, right? Thankfully, Nebraska is not one of those states that has a telepresenter requirement, and it's also less restrictive in terms of telepharmacy requirements. On the other hand, Nebraska does not reimburse Medicaid providers at parity for store and forward telemedicine. So store and forward is basically whenever you take information, telehealth information, you input it into a device and send it somewhere and it stays for a little bit and then they evaluate it. So this is particularly important, for example, in dermatology. So you might have a rash or something that you take a picture of it and send it, and they're not necessarily going to look at it right away, but in the next day or two, they'll have it whenever they have a chance, they can look at it. Different states reimburse at parity for this. Before the crisis hit, Nebraska was not reimbursing Medicaid providers for this at all when it was offered via telehealth. So moving on to the second idea is, what do we do with all these regulations so that have been suspended? So the first thing is just a few observations. as a general rule, neither federal nor state regulations nor local regulations, it's exceedingly rare for them to go away, right? Once a regulation is created, it is essentially a life, it has a life of its own, and it is immortal, right? However, regulations have this unusual dynamic in terms of their costs. So as Dr. Timmons has noted, many regulations have greater costs than benefits. But those costs and benefits are not equally distributed. Quite often, the benefits of a regulation are concentrated on highly organized interest groups. So these are typically anti-competitive benefits. The regulation will raise the costs of their rivals, or it'll limit entry into that industry and allows them to earn higher wages and be sheltered from competition. Their costs, on the other hand, are borne by the consumers who have to pay higher prices, or maybe even go without care or go without the product or service that's subject to licensure. So because of the fact that many of these regulations impose costs on a highly diffuse and unorganized group like consumers, they typically aren't very good at fighting these rules. To go to the example of certificate of need laws, I've testified in about 12 states on these issues. And sometimes there is another economist there, or maybe somebody from the Department of Justice to talk about the anti-competitive effects of these rules. But quite often it's just me. And on the other side, it's lined up deep will be, a dozen people representing the hospitals that benefit from the anti-competitive effects for these. Same thing goes for occupational licensing. I will testify in state legislatures, and there will be an economist or maybe an antitrust authority talking about how licensure protects providers at the expense of consumers. And then there will be 20 or 30 electricians or cosmetologists or others there to talk about how licensure is vital for consumers. By the way, there's almost never can they round up a consumer advocate to claim that licensure is beneficial for consumers. They almost always have an industry insider claiming that licensure is beneficial for consumers. And that's really because the evidence is just not there that licensure benefits consumers. So with those two ideas in mind, what we're arguing is that realistic reform recognizes this concentrated benefits and diffuse cost dynamic of regulation. It recognizes that regulations typically don't go away. And what it will do is it will borrow some of the aspects of successful deregulation. There hasn't been many successful deregulations, but there have been a few. And what it will do is it will allow policymakers to cast conspicuous votes for the general interest. Allow them to cast a big, obvious vote that says, I want to deregulate. But it will give them some cover from special interest pushback. It won't allow special interest to come in and apply a great deal of pressure on policymakers to keep the anti-competitive rules. So what does that look like? Well, we suggest a three-step process. So first, don't bring the rules back right away. Keep them suspended. And then identify and study all the rules suspended or modified during the crisis. Ideally, this will be done by an independent committee composed of experts who have no financial ties to the industries being regulated. That is key. You can't allow electricians to sit on the board that decides if we ought to get rid of anti-competitive rules that protect electricians, right? Instead, you have people who know the literature, know the science on the effects of licensure on the public's health and safety and costs, and you allow them to make a unbiased judgment on what's been the effect. And thankfully, this stuff has been studied for 30 years. We have lots and lots of data to draw on. And we also, thankfully, we have this experiment going on across the country with hundreds of rules being suspended or modified. So we can not only look at the past data over the last several decades, but also the new data that's emerging today. So have this independent commission formulate a set of recommendations for each of these rules. And then ideally, you allow the legislature to just have to cast an up or down vote on it. So this is borrowing some of the logic from successful past reforms like base realignment and closure commissions, which managed to do what Congress had not been able to do for decades, which was close obsolete bases. You know, military brass for years had said, let's close a lot of these bases. They don't make strategic sense. But individual congressmen and women canceled that because while they didn't make strategic sense, they made political sense because they meant jobs in the districts. Well, in the 1980s and 1990s, Congress created the BRAC commissions. This was led by Senator Phil Gramm and Representative Dick Armey. And the idea here is Congress, again, can pass a broad conspicuous vote that says we're going to get rid of obsolete and unneeded bases, but leave it to a commission to take the heat on what actual bases are closed. And then we in Congress let the commission's rules, suggestions take effect automatically, and it would take a affirmative action of the legislature to actually overrule that. And so we're recommending something similar for regulations that have been suspended or eased during the crisis, is allow these rules to automatically sunset or reform as part of a package deal. And that will take some heat off the legislators, the policymakers, so that they are not the target of special interest pressure. So with that in mind, I am happy to answer some questions. I've got my contact information there. I would be delighted to keep the conversation going even after this call. So thank you so much again for your time. It's a pleasure to have the chance to talk to you guys today.
All right, thank you, Dr. Mitchell. A quick question: Are you familiar with transportation certificate of need laws by chance?
A little bit. So, you know, the most prominent area where they exist is in healthcare, but I believe that they actually started in many cases in transportation. So some of the first certificate of need laws were in the railroad industry. Now they're relatively common still in for moving companies. Sometimes you'll find them also in states. There'll be a regulation of ambulance services that will fall under the transportation con, even though it does affect healthcare provision.
Yeah, the reason why I asked that is because here in Nebraska, we do have a specific transportation certificate of need law, the certificate of public convenience and necessity, for those wanting to provide some non-emergency medical transportation for passengers. And so, yeah, I was just going to ask if you were familiar with other states that either currently have these laws or used to have these laws, and what they had done to, you know, resolve those problems, get them off the books.
Yeah, what I would recommend is there's a Mercatus paper by Timothy Sandifer that looks a little bit into the history and the legality also of these rules. They are often called competitors' veto laws because for a couple of reasons. One, even though the evidence on licensure and the connection to public health and safety is quite limited, at least there is the story, the goal that that's what licensure is doing. In the case of certificate of need, there's not even that. They don't even pretend that these rules are necessarily to evaluate a transportation provider, their safety or anything. It's usually just about limiting quantity because the idea somehow is that the community doesn't need the product or service. They're also called competitors' veto laws because they do give so much authority to those who are already in business to block them. So Timothy Sandifer has a nice paper that details some of the legal and economic history of those rules. And in there, I think you'll find more research on their effects on quality and safety.
Okay, great. Thank you.
Here's a question from one of the viewers, and you may both want to weigh in on this a little bit. It's a little bit situational and philosophical, I guess. How do you reconcile the fact that healthcare is one of the hardest hit industries in terms of job losses during the pandemic? Wouldn't this tend to indicate that a shortage in professionals is more on paper rather than in practice? And why open up licensing when those with licenses lost their jobs?
Well, I can address maybe part of that. So, the biggest factor here is that non-emergency trips to the doctor have been canceled. So elective surgeries are canceled. Even breast cancer examinations have been canceled. This has both a financial effect and a health effect. On the financial effect, these elective surgeries are the bread and butter for most providers, and this is true for extremely profitable and large providers like Mayo Clinic that is they're hemorrhaging money. They've had to furlough and lay off a lot of workers, but it's also true for small clinics that are also losing money. And it's unfortunate because this is how they make their money. And yet usually they would use this money to cross-subsidize emergency and other types of care, such as that which is needed right now to fight the pandemic. And so at the same time that we're asking people to step up and provide more care, we're also depriving them of the resources to do that. It also has a health consequence. So in April of last year, I believe about 20,000 people in all of the month had been diagnosed with cancer. This year it was on course to be less than 5,000. This doesn't mean that they're not getting cancer. It means that they're not getting diagnosed. So this is just one aspect, but there's lots of people that are missing important medical care that has not been considered urgent, and therefore they're not able to get to it. So I think that's the big factor. As maybe Dr. Timmons can talk a bit about how that might relate to licensure in particular.
Yeah, I mean, if there's concern about perhaps there being too many professionals, I think the market would more or less react to that. I mean, if nurses, for instance, see that there aren't potentially as many opportunities for them, then probably more or fewer individuals are going to see careers as a nurse. I don't think licensing would be encouraging more folks to come in inadvertently, and us having a surplus of nurses. I think that would more or less take care of itself.
All right. Okay, I've got a question here in our chat box. Assuming licenses provide some measurable assurance of a superior service from license holders versus service from those who have not objectively demonstrated their knowledge and skill base, a regulatory board ought to forecast greater death rates and greater injury rates from non-licensees. So what dollar value of human life and what chart of values for various injuries ought a regulatory board use when calculating whether to choose increased, constant, or decreased regulatory oversight? And I'll let either of you tackle that one.
So one aspect here is the question of, does licensure actually increase quality or safety? And the story is plausible that if it is a well constructed quality gate that only lets the high quality people through, or somehow the education requirements really, as Dr. Timmons said, build the human capital, give people the ability to better serve, then yes, it could increase quality. But that needs to be weighed against a few other factors. So on the other hand, licensure limits the competition, and it limits the number of providers. And we know that competition itself in healthcare as well as in other markets is one of the better predictors of quality. As competition goes up, quality tends to go up. And so by limiting competition, it may undermine quality. There's another aspect. It raises prices and limits the number of providers, and that can cause people to be less able to access the care, and that can undermine quality. So for example, there have been a number of studies that have found that when there's fewer providers and higher costs, people are likely to skip the service or the care, and that can cause problems. So one study, for example, found that greater stringency of licensure of electricians was associated with more do-it-yourself home improvement projects, and actually a statistically significantly higher number of electrocutions, death by electricity. So there you have this idea, well, boy, licensure should decrease public harm, but it actually seemed to increase public harm. You saw there's similar studies that found that people skip optometry, eye exams when there's more stringent scope of practice for eye care professionals. People are less likely to obtain dental care. There's even more incidents of animals with rabies when the licensure of veterinarians is more stringent, because there are fewer veterinarians around, and the ones that are around are able to charge higher prices. And so dogs and cats go without vaccinations, right? So it's not, you have these two theoretical forces that are pulling in opposite directions. We have to look to the data. What does the data show? Well, more than half of the studies find no statistically significant or mixed results. So the basic, the most likely result is that licensure, it's sort of a wash. But interestingly enough, there are actually more studies that find that licensure undermines quality than that it increases. So among those that do find statistically significant results, about twice as many find that it depresses quality than that it increases quality. So that the very first thing out of the gate is, before you even start saying what's the value of a life, we need to be thinking about, is this even an appropriate instrument to try to protect the public? You know, it's one thing to say we want to protect the public, but you know, it's a huge mistake to say that the goal justifies the means if the means doesn't get you there at all. So maybe Dr. Timmons probably has more to say on this. He's you know, the expert on this.
No, I think you're making all valid points, Matt, and I think particularly when we're talking about scope of practice reforms, all that we're talking about is just allowing healthcare professionals to do what they're trained to do. And in a number of states, you know, thankfully Nebraska does have full scope of practice for a number of health professionals, but not for others. What the law is saying is you can't work and do the things that you're trained to do. So a lot of studies, as Matt has mentioned, have looked at do changes or do differences in scope of practice affect quality of care. And most studies find that if you let nurse practitioners practice to the full extent of their training, or you allow certified nurse midwives, for instance, to practice without having a collaborative practice agreement or supervision of a physician, that if anything, there seems to be some quality improvements. You know, for example, a study looking at certified nurse midwives found that you're less likely to have cesarean sections and induced labor if you do have a regulatory structure where nurse midwives can practice more freely. So the evidence seems to suggest, if anything, that licensing at best has a mixed effect on quality and doesn't seem to be fulfilling its intended purpose.
Okay, so we have a number of questions that have sort of piled up. If you gentlemen don't mind staying with us for a few extra minutes, we might try to crank through those. And for those who aren't able to stay with us online, do feel free to come back and check the video later because it will be available. Matt, there are two questions that I'm going to try to combine here, but they refer back to your presentation. The one question is, how many states have passed legislation creating parity for store and forward? But also, do you have a sense of how how Medicare reimburses for telehealth, or if it does, and what percent of private insurers do as well?
Oh, that's great. I regret that I probably don't have fully satisfactory answers to any of these questions. But I can tell you where to look. So my colleagues at the Mercatus Center, Dr. Bob Grayboys, and a few other colleagues have a paper called the HOPE Index, HOAP. It's healthcare. It basically measures healthcare openness and access project. It measures the degree of regulations on healthcare. They have an answer to that question on how many states reimburse at parity. I can consult it and look it up and get you the answer, but I don't have it right now. So on Medicare reimbursement, my understanding is that that was one of the first rule changes that the federal government rolled out probably about 5 or 6 weeks ago. Is they did change it and made it easier for physicians who offer telehealth to be compensated for doing so. They also made it easier for physicians who are licensed in one state to be reimbursed through federal programs when they offer telehealth to patients in another state. So I believe the federal government has taken a number of actions to already ease it, but at the state level, there are still restrictions in many states. Did that answer somewhat the questions? I know it didn't answer the first one because I just don't know.
Okay, do you want me to take the next question, Laura? Okay. Okay, so in those states where the commission has been established as recommended to examine barriers to professions, how have you overcome the unconstitutional delegation of legislative authority argument?
So the typical idea is that the buck does still stop with the legislature in that they can always reverse it. So, but what is key is it's usually put together in a package deal. So they have to, if they want to reverse the recommendations of the commission, then they have to do so all or nothing. So that's generally, I think, how you've seen it sort of play out. There are many state legislators who don't want to give up that authority and are wanting, are resistant to have to tie their own hands and do it as a big package or not at all. So it's more of a practical concern than a constitutional concern, as I understand it. But what I would say to the state legislators is this is actually sort of welcome for you because it takes some heat off of you. It allows you to again, you're still casting the obvious vote, the conspicuous vote that everybody can see for the whole package, but you can take some heat off and say, look, I'm deferring to the experts who have studied this on what particular level of regulation is necessary for particular types of professions.
Okay, thanks. And this one I think is probably for you, Ed, in some way. Can you expand a little bit more on why universal recognition is so important? Like Nicole suggested earlier, we had a bill here in Nebraska, probably not going to make it through this year, but we have hopes that it will next year. But why is it so important, especially in the midst of a COVID-19 crisis, but for any sort of a natural occurring event?
Sure. So as I mentioned during my remarks, licensing has been shown to reduce mobility of workers. So workers are less likely to move from state to state as a result of occupational licensing. So if workers or if businesses are having a hard time finding skilled professionals within the state, I think opening up and recognizing licenses from other states gives businesses an opportunity to find the workers that they need. So I think the economy as a whole can benefit from getting access to workers that have certain skill sets that it might take a lot more time in order to fill those gaps or to fill those shortcomings without simply allowing workers from out of state to move in. So, I think just adding that degree of flexibility into the labor market, I think can stand to benefit everybody in the state.
So Arizona, I think, was the first state to implement sort of a universal recognition practice. It's been about a year ago now. Do we have any sort of results? Has that worked out well for them, or has it been a mess?
Yeah, so it's still early, but the early data that we have from Arizona suggests that the law has been successful, and you have seen several hundred licensed professionals enter the state and begin working as a result of passage of the law. And Nebraska would not be stepping out on a limb here. There are a number of states that have enacted similar reforms. Pennsylvania, my home state, enacted a recognition law. Montana, Utah has also enacted a recognition law, and the law very well may be forthcoming. It seems to be forthcoming in Missouri as well, with the legislature, both sides passing the legislation. So the early returns do seem to suggest that passing universal recognition does in fact lead to more workers coming into your state.
Great. Nicole, I'll take this one, I guess. Here's a question. When you start talking about licensing of any sort, and you can both jump in on this if you want, the question of whether or not you have to have tort reform in some places, and I don't think either of you are lawyers, but tort reform is a question, especially with respect to medical licenses, but others as well. Does that need to go hand in hand with licensing reform?
I think the exposure of legal liability is a concern. As was mentioned, the jury's kind of out if in fact licensing does in fact improve quality, and businesses are still free if they so choose to have more stringent regulations or requirements. For example, there's no state, to the best of my knowledge, that requires nurses to have a college degree. Yet, nevertheless, hospitals generally do have that as a requirement. So businesses would still be free to choose, if they believe that it's in their best interest, to have additional requirements, to have more required than what the state government, or what in some instances the federal government, when it comes to licensing, might mandate. So ultimately, businesses would still have that ability to decide, well, if I don't want to give myself this amount of exposure, and they'd have to do that calculation, they might insist that their workers have XYZ credentials. And ultimately, competition, I think, to some degree, would help sort that out as well.
One quick aspect of that is just that it highlights that how many other types of public and private governance mechanisms keep us safe. So, as Ed mentioned, there's the NBER study that suggests that most consumers turn to consumer ratings. There are also of course, insurance companies that they want to limit their payouts, so they too will do their own kind of governance, so their own kind of regulating to make sure that firms are aren't taking undue risks. There are private certifiers. There's Underwriters Laboratory. There's Angie's List. There's Consumer Reports. There are hospitals that have privileging that practices where, as Ed mentioned, a psychiatrist in most states, maybe all states, Ed, you would be able to tell me, can legally perform surgery under their license. It's not the license that keeps them from doing so. It's the insurance companies, the medical malpractice insurance companies, and the hospitals that would quickly revoke hospital privileging to any psychiatrist who's performing surgeries when they shouldn't be, right? And then there's rules against, and there should be rules against fraud, deception, and there is tort. Tort can perform a useful function if somebody has been negligent or caused harm. They should be held liable for that. I'm not saying that the tort system works perfectly, but it is in some cases a mechanism that keeps us safe in a way that actually licensing probably doesn't.
Great. And we have one last question for today's webinar, and that is, how much weight is given to malpractice liability data when examining if quality has improved with loosened scope of practice?
So there was a study that looked at expansion of nurse practitioner scope of practice, and they used the premium on malpractice as a gauge of quality. And what the authors found is that in states that have broader scope of practice for nurse practitioners, there is no increase in malpractice premiums. And I did a paper looking at optician licensing and whether or not if a state, opticians are folks that are just fitting eyeglasses. Some states require licensing. Off the top of my head, I can't remember if Nebraska licenses opticians or not. They might. There's just a handful of states that do. And what I found is that in states that license opticians, there wasn't any reduction in the malpractice insurance cost, the premium. At least in those studies, there doesn't seem to be any connection there using the malpractice insurance premium as a gauge.
All right. Okay. Well, I'd like to thank both of you today, Dr. Ed Timmons and Dr. Matt Mitchell, for joining us and presenting. There's a lot of good information that we covered. I'd also like to thank attendees for participating in our webinar today and learning a little bit more about some of the regulations in our state dealing with healthcare. Just a reminder that this webinar has been recorded, and we will be posting a recording of the webinar as well as the slides on our website at plattinstitute.org. And also, when you leave or when you exit our presentation today, there will be a survey. So we would appreciate you taking some time to fill out the survey and give us some feedback on the webinar. And also, just to let you know, we will be taking next week off, but we will resume webinars, and our next one will be June 3rd, and we'll be featuring Dr. Ernie Goss to kind of talk a little bit more about some of the economic impacts here in our state. So thanks again, everyone, and have a great day.
Thanks, everybody. Appreciate it.
Thank you.